I don't know if you guys wanted to kick off with some words before we keep going. We have a jam-packed PowerPoint here, so I want to make sure we have as much time as possible.
Hey Rob, if you are ready to go, we will let you go ahead and get started. We are going to record this session again for the clinics, and we'll get the link to you after, along with the slide deck. Rob, I would like you to clarify, however, how do you want to address questions during the session?
Yeah. If you can put your questions in the chat as you have them, the way I have my screen, I should be able to see them. And if it's something that is timely for then, happy to answer it. If it's something that, I might get addressed in a slide or two, I may not address it at the moment, but there should be enough time also for questions at the end. So any questions during, if you can put them in the chat, that'd be great. And then we can just go from there.
All right. Well, it looks like we've got a pretty good group of people here, so feel free to take it away.
All right, great. And just confirming that you guys you're seeing a presentation on your screen.
Yes.
Okay, great. All right, well, good morning, everybody. Again, I assume most people here were on the first training, but just as a reminder, my name is Rob Roten. I'm with Myers and Stauffer. We are one of the vendors that Louisiana has contracted with to help initiate the CCBHC program in the state. Specifically, we are the PPS and cost report group. So the purpose of this training, the first one was a very brief overview of PPS methodologies generally. This training, we're going to be going a little bit more in depth, specifically talking about the cost report itself, because when we talk about PPS rate setting, the cost report is what drives that rate setting. So
Rob, I'm going to pause you for just a moment. If you're not
go ahead.
speaking, go on mute. We're picking up some background noise. Thank you.
Okay. So a quick agenda, and I'll say just from the start, we have a lot of slides in here. Some of them we're going to go through pretty quickly. We wanted to include some additional information in here for you for when you get the slide deck itself that we're not going to necessarily spend a lot of time on here. But we're going to start with just a really brief PPS1 refresher, a few slides that I think are really important from that training that we had a few weeks ago. And then we're going to start working our way through the cost report schedules themselves. That is that's going to be the main majority of this training. We're going to talk a little bit about the cost report submission overview, kind of the process of what that's going to look like. And then, as I mentioned, we'll have some extra time at the end for questions. So really quick, just to make sure everybody's on the same page with PPS1. So PPS1, again, it's a daily methodology where you will be paid a predetermined fixed amount paid on a prospective basis. The rate calculation itself, again, is very basic. When it comes out, it is just your costs divided by your visits multiplied by a inflationary measure. And then your costs do get split out into direct costs and indirect costs, which is something we're going to focus on a lot when we start getting into those PPS schedules. A little bit more about the rate components. So I just kind of mentioned the two big things are your direct costs and your indirect costs. Your direct costs, when we talk about those are your direct CCBHC expenses. So that's your staff costs, any, contractor staffing that you have, other direct CCBHC costs. Those are all your direct CCBHC expenses. And then you have your non-CCBHC expenses. These are any direct costs. So there's still direct patient care costs, but they're not actually associated with providing CCBHC services. And then you can also have non-reimbursable costs. Indirect costs, these are your site costs. So, costs for your building, utilities, that kind of thing. And then administrative as well. So that's kind of your executive salaries, any other administration, accounting, legal, that kind of thing. Since these are your first cost reports, you are allowed to include anticipated costs, which those anticipated costs, those are estimated expenses that you guys will be kind of required to incur in order to come up to that CCBHC certification criteria. So hopefully this is all just kind of a refresher from that first training. Another way that we wanted to show these direct care costs, because this will be very important when we get into the actual cost report schedules themselves, is again talking about your CCBHC expenses versus your non-CCBHC expenses. Because your direct, when you think about direct care costs, that's costs that are kind of touching a patient, right? So your staff costs, medical supplies, things like that. But you have to be able to bucket those expenses into CCBHC expenses and non-CCBHC expenses for the purposes of this cost report. Direct versus indirect, I kind of just explained direct. So the indirect costs, again, that's just your overall overhead for your facility. So business office salaries, maintenance, utilities, legal and accounting. And I know I'm going a little quick here. Like I mentioned, this is really supposed to be just kind of a refresher of that first training. Some terms that are really good to know, just so that we can be speaking the same language, because lots of people, use different terms for different things. A cost, an expense, it's the amount that you're paying to purchase something. A revenues are income. It's what somebody pays you for services that you provide. It can also be things like donations and grants, or some other stream of revenue you have. Visits are very important. That's kind of the core, one of the core purpose or parts of the PPS rate. And a visit is an instance of providing an allowed CCBHC service to a patient. We have our fixed assets. Those are our larger expenses, such as a building or some very expensive medical equipment that you will depreciate over multiple years. And then again, the anticipated costs that we've already mentioned. Generally speaking, allowable cost that should be filed on these cost reports, it's anything that is necessary and proper for operating and maintaining your facility and providing those core CCBHC costs. Here's some very basic examples of what an allowable cost is. On the flip side, of course, you have your non-allowable costs. Non-allowable costs, easiest way to explain it is it's just not related to patient care. And some examples of those, of course, are the biggest, most common one is just bad debt. Any charity donations that the facility will expend. So if the facility or if you as a provider donate to a cause, that's not an allowable expense. Lobbying costs, political contributions, marketing, all of those are your kind of core basic examples of non-allowable costs. Okay, so that was the refresher. That was probably very quickly, very fast, very quick. I understand that. We're going to slow it down a little bit here as we walk through all of the different cost report schedules. So again, just kind of as a reminder, these cost reports are what you're going to need to create, and they are what's going to be used to calculate your PPS rate. There's a lot of different schedules as part of the cost report. And we're going to walk through every single one and we'll explain exactly what the schedule is, what the purpose of it is, how it needs to be completed, and also just some other key kind of what's really important about them. So again, if you have any questions, feel free to pop them in the chat, and then we'll also address some after. This is the general flow of the cost report schedules. So it starts with just information about you as a provider, and then you run through all of the various financial tabs of the cost report. All right. This is the very first tab when you open up the CCBHC cost report, and it is simply just provider information. So throughout this, you'll see screenshots. So hopefully this looks familiar to you when you go to actually open up a cost report if you haven't looked at it already. But the purpose of the provider information tab is just to provide, for lack of a better word, provide information about you're able to, this is where you identify the location of your facility, the name of your facility, all of the IDs that you have. I know that you guys will eventually be receiving CCBHC specific IDs. So at some point you'll need to have those. But for now, it'll just be, your standard Medicaid IDs. The tab for provider information is kind of broken up into two spots. One of them is for if your facility is a single site. So if you only have one location, you only need to fill out the first part where you provide all of the detail about your location. If you are a provider that has multiple locations and multiple sites, you will need to fill out the first part for the consolidated kind of central office area, and then you will need to fill out the detailed information for every single one of your sites. The cost report allows you to copy and paste the tab throughout, and that is how you will, be able to say, okay, I have location one, here's the name of it, here is the address, so on and so forth for each one of your locations. Okay. Next, you have what is arguably the most important tab of the entire cost report. This is your trial balance tab. The trial balance tab itself is broken up into multiple different parts that follow the cost descriptions that we kind of already went through. So it starts with your direct CCBHC expenses, it moves into indirect cost, and then it finishes with direct non-CCBHC. If you've ever seen a cost report before, hopefully this looks relatively familiar. It does kind of follow the same general idea. Down the left side, you will see different cost centers. In the CCBHC cost report, the first part is staff cost, and there's very specific staff positions that we have asked you to split your cost out into. That's all the way on the left. And then you will have two input tabs. That's compensation and other. The compensation column, this is for the salary cost of the person. And then you will have the other column as well, which could be any other costs associated with that. You could put fringe benefits in that, all of that. After columns 1 and 2, you have a subtotal in 3, and then tabs 4, 6, and 8, or sorry, not tabs, I apologize. Columns 4, 6, and 8, these are all formula-driven columns from various other tabs throughout the cost report. You'll notice that they're grayed out. Anything that's grayed out is something that you do not need to complete. It will be pulling in from a different area. So again, the first section of the trial balance tab is your CCBHC staff expenses, and we do expect you to be able to categorize your costs into different cost centers. So in order to do that, to take a quick break from looking at the different tabs itself, is we wanted to talk about creating a crosswalk. So for your trial balance tab, you will need to be able to take your internal trial balance and group and crosswalk it into the various cost centers that are listed on the CCBHC cost report. So we wanted to explain here how you go about doing that. Step 1, you'll just take a listing of all of your trial balance accounts. I'm sorry, was there something there? Okay. We'll start by just taking a list of all of your trial balance accounts. This should include all of your CCBHC services visits, regardless of payer, all of your expenses. You will then identify where those trial balances will be filed on the trial balance tab of the cost report, and you will identify the cost report line and description next to every single trial balance account, and you will then summarize those costs based off of that cost report line. So what that would look like is here. So all the way on the left side, we have an example of what a trial balance would look like, maybe coming out of your out of your accounting system. So you have all of your account numbers. We have the titles of the accounts, and then the trial balance amounts themselves. Step 2 is where you would crosswalk them. So you take all of them and you identify the cost report line that you believe that trial balance account should go into. So that's what you can see here in your kind of middle column. And then step three, this is where you summarize it all and you can sum up if you're adding, because you can add various different trial balance accounts into one line. You would then summarize it into a mapping, um, which you can see over here in step three. Okay, so going back to the trial balance tab. So I mentioned 1A, this is your direct CCBHC staff costs. Under that, your next part is part 1B. This is CCBHC costs under agreement. This is where you would put any DCO costs if you're choosing to contract with the DCO. And then part 1C, this is your other direct CCBHC cost section. So here again, you have, medical supplies, transportation, depreciation. There are some kind of stock categories for you. You'll notice when we send out the cost report to everybody, there should be two versions, one of which is macro enabled and one of which is not. On the macro enabled version of the cost report, you are able to add additional lines. So if the lines that are in here do not necessarily make sense for a cost that you have, you are able to add additional lines. We do generally ask that you at least attempt to categorize your expenses into the already given cost centers. But we do understand that there will be times where you guys may have an expense that doesn't really fit. And in that case, it's perfectly fine to add a line. All you have to do, it's just a button. You click the button and it will automatically create a new line for you to be able to add in a description and a cost. Next, still on the trial balance tab, I mentioned this is a very important tab, so it is quite long. You have part two. So part two, this is your indirect costs. And again, going back to talking about the different types of costs that you have, this is where it breaks it out into those two different indirect costs, which are your site costs, which again, you can see here, you have, rent expense, utilities, depreciation, housekeeping, and then you have your administrative costs as well, which are things like office salaries, insurance, accounting, legal. And again, you have that option to add additional lines if needed. The last part of the trial balance tab, this is your non-CCBHC related expenses. So again, I mentioned, you guys may have direct costs that are associated, with providing patient care, but it's not necessarily for providing CCBHC services. In that case, you would need to be able to identify those costs, split them out, and file them in part three, which is that direct cost for non-CCBHC services. In this section, they don't give you a lot of area, pre-described cost centers for these costs, just because these can kind of be anything and they do vary from provider to provider. So feel free, again, to utilize the macro to add additional lines as needed. But the non-CCBHC services is broken out into two sections, one of which is the direct cost for services other than CCBHC, and then your non-reimbursable costs. And I'll just kind of add here, where we see kind of providers, kind of trip themselves up is really the classification of these costs. If you provide services in your facility that are non-CCBHC, so for example, if maybe you're an FQHC, you generally maybe provide primary care services or just other costs that are non-CCBHC, you really need to think about what costs are associated with the CCBHC and what are not, and categorize them correctly. Because that is kind of one of the more difficult things to do when creating this cost report, and it's one of the most important for coming out with a accurate PPS rate. Okay. So the next tab here is trial balance reclassifications. The next few tabs, slides that we're going to go through, essentially what we're doing is we're working our way from left to right across the trial balance tab. So I mentioned that the Columns 4, 6, and 8 are driven from other places of the cost report. This next slide that we're talking about, this is what drives column 4 of the trial balance tab, which again is reclassifications. So reclassifications, this is where you are able to shift cost around throughout your trial balance tab. So why would you do this? So the main reason here is if once you go through the exercise of categorizing all of your costs, mapping them to the various different cost reporting schedules, you may have some accounts where maybe a portion of them really should be in a different section. So the way that you would move that is through a reclassification. And you can see an example here is kind of on the bottom of the slide. In this case, this provider had a medical director that was also a psychiatrist. So what they did was they filed the psychiatrist cost in the CCBHC direct staff cost area, which is correct. But then they took out a portion of that salary that is related to being a medical director, which is more of an overhead indirect cost, and they reclassified a portion of that staff's salary into indirect. So the way you do this is you just provide a brief explanation of whatever the reclassification is. So again, in our example, you see it's just simply medical director. And then columns 1, 2, and 3 are for the increase. So again, looking at our example, they are increasing the office salaries amount by 28,800. So they identify the cost center, which is office salaries, the cost center number, which is cost center number 4, line 40. And then columns 4, 5, and 6 are for the decrease. So again, identifying it, they're taking it out of psychiatrist, which is line 1, and it is in the amount of 28,800. Really important on reclassifications. For a reclass, you can move costs into multiple different cost centers with one reclass, but at the end, it all has to net to 0. You are shifting cost throughout. You are not adding cost. You are not removing cost. So a good check just to make sure that your math is correct is that your reclassifications column at the very bottom should be 0. Again, this is formula driven. So if you fill out this tab, it will automatically shift back to the trial balance tab. Next, we have our trial balance adjustments. And this is column 6 on our trial balance tab. Trial balance adjustments, this is where you will, if there is a cost that is on the on your trial balance tab that should not exist on the cost report, it should be fully removed. This is how you would do it. Most commonly, we will see this for revenue offsets. There may be instances where you receive revenue that should be offset. A common example there would be if you receive, like a rebate or something for something that you purchase, which is what the example here is. You would insert whatever the amount is. So in this case, it was just $125 where you are offsetting that. So in this case, it was for medical supplies in line 22. And it will automatically flow over again into the trial balance tab of the cost report. Let's see. There's 2 parts to this. It does give you a listing of kind of common adjustments. So if you're not sure, what are some things that I should be making sure I'm adjusting off of my cost report? There are some examples here. And I believe, yes, okay. And then there is another section for costs that are non-allowed. So I already mentioned some non-allowable costs are things like bad debt, charitable contributions, lobbying. This would be a portion where if you file it on the trial balance tab, you can then remove it here. So in this case, the provider had a late fee. Late fees are a non-allowable expense. So those should be removed from the cost report. So the provider is identifying, saying, okay, I had $60 worth of late fees. They provided the description in the description column, and then they identified where that amount is coming from. So in this case, it was the bank fees cost center, which in this case was 47A. Okay. There's a lot on this screen, but it's a very large tab. So hopefully this is a little clear. This is our last kind of main trial balance tab. Going back to our trial balance tab, this is column 8. So this is your anticipated cost. Let's get back to where we were. Okay. So the anticipated cost tab, this is where you will enter the anticipated cost that you guys have calculated, have determined as part of your cost report submission. The tab itself directly mirrors the trial balance tab. So every single one of the cost centers throughout the entire tab links directly to the trial balance tab. And what you'll see is you will have 3 columns for you to complete when you are adding anticipated cost. The first column, and this is only obviously applicable for staff costs, you are asked to include, if you're increasing staff costs, what is the FTE associated? So you can see the example here in the top left. This provider is adding 1 full FTE as a psychiatrist for $130,000. So they've identified the amount and they've identified the FTE. There is a reduction expense amount column as well. That's column 3. So if as part of your CCBHC program, maybe you are adding a position but removing another, you would obviously add the amount to column 2 and you would remove the amount from column 3. So again, we do, as staff cost is, it's the largest cost of any as part of your facilities. And a lot of the anticipated costs, a lot of that is related to staffing salaries. We do ask that you provide the FTE amounts that are associated with the salary increases. That's one of the ways that reasonableness checks can be completed. In addition to staff salary, I mentioned that that everything ties back to the trial balance tab itself. So there are sections for other CCBHC costs. Here an example is EHR costs. We've mentioned before that enhancements or upgrades to EHR programs that are necessary for CCBHC certification are allowable anticipated costs, and they're relatively common. We see them often. Those can be filed here, and you would file them under the EHR line on the cost report. And I'll give a plug here for general anticipated costs. As a reminder, these anticipated costs are supposed to be what are reasonable and necessary for you guys to become CCBHC certified, things that you believe you will be expending in that first year. It's only for the first year. It's not for an extended period of time. If you are believing you're going to, build a new building in 3 years, that's not a next year expense. That would not be an anticipated cost. So you're really only looking at that first year of operation as a CCBHC. What is it that you need to hire? What are the supplies that you need to purchase? Those are the items that would be considered allowable anticipated cost. Everything that you file here, we will be just asking a general explanation as, what is your reasoning? Everything on here should have a purpose. It should be tied to something, a specific reason for why you need to expend that. Otherwise, it potentially would be disallowed. Okay. I skipped ahead a little bit, right? So, but again, anticipated cost, documentation, what is the cost? What's the reason for it? If it's an estimate or an allocation, how did you come up with that amount? If you're saying that you're going to hire somebody and you're going to pay them $80,000, what's the basis for that $80,000? Is that what you're currently paying that position? Is that the, salary average for that position in your region? Those are all, typical explanations that we receive. Really, we're just trying to make sure that you guys are thoughtfully thinking about this and you're not just kind of, coming up with numbers out of thin air. Some examples, I already kind of mentioned, FTE salary, staffing needs are probably the most common anticipated cost. If you need to add specific FTEs in certain areas, to be able to provide the CCBHC services, very common anticipated costs. And then again, I already mentioned the EHR example. Okay. Indirect cost. We talked about this in our first training, but it is also very important. So I want to make sure I go through it again in detail. So you are required to file your indirect cost on the trial balance tab that ties to your financials. However, that's not necessarily how your indirect cost may be calculated. As a CCBHC on this cost report, you are required to select one of 4 methodologies for your indirect cost allocation, and I'll run through them all now. The first methodology that you are required to select, if it is applicable to you, is federally approved indirect cost rate. So if your facility has a federally approved indirect cost rate, also known as an FIR, which has been approved by a federal cognizant agency, you are required to use it. You cannot select another indirect cost methodology. You are required to use that federal indirect rate. If you do not have one, then you do have a selection. The first is if you are eligible and meet the requirements for the federal de minimis 15% rate, you are able to use that. I know there's very specific qualifications for that, however. So, if you're not sure if you're eligible for that, I would, potentially look into it. The next would be the allocation percentage of direct cost. This is where, and this is probably the most common allocation methodology that we see for providers that do not have an FIR, is essentially it allows the cost report to allocate your cost based on how you filed it on the trial balance tab. So this third option, what it does is it takes your total direct CCBHC cost, your total direct non-CCBHC cost, comes up with a percent to total, and it will allocate your indirect costs between the two. Finally, there is a last option, which basically just is you allocate your indirect cost how you think it should be. Most commonly, if we see this, it's because you're part of a very large, like a hospital system or like a large conglomerate, and you guys have specific ways that you allocate your indirect costs. This is not common, and I will say, if you do believe you want to pursue using your own methodology for allocating your indirect costs, it does need to be approved by the state. And I would recommend potentially reaching out ahead of time or while you're creating that cost report, just to make sure that what you are planning on doing will be actually approved by the state. Okay. So now we'll move into a few slightly easier tabs. The first one is an allocation descriptions tab. So as you're completing your cost report, you may find an instance where you have a cost that fits into multiple different categories. And in this case, you may decide that you need to allocate some cost. So, if you're allocating a salary amount between 2 different sections of the cost report, because maybe they do CCBHC and they do non-CCBHC, this is a tab where you will describe what that allocation methodology is. So for example, a common allocation methodology we see is just based off of encounters. So if you have a staff who does CCBHC and non-CCBHC, and you say, okay, my facility, looking at these encounters, they provide 100 non-CCBHC and 100 CCBHC. That's a 50-50 split. You allocate the cost 50-50. On this tab, that's where you would just explain, hey, this is what I am doing. Really, the biggest purpose for this is just to expedite the cost report review. Anytime that there's a cost report allocation, it's something that we verify to make sure that we agree with the methodology. So if you proactively input all of your allocations in here, it will, potentially speed up the review process. Okay. Next, we have the daily visits tab. So on the daily visits tab, this is where you will file your actual encounters for CCBHC services. There are three different lines that need to be filled out here. The first one is the CCBHC services that are provided directly by your staff. The second would be CCBHC services that are provided by a DCO, if that's applicable to you guys. And then the third one would be anticipated daily visit increases. Going back to the anticipated costs, something that we would expect to see if you're planning on adding specific services that are required under the CCBHC program, which relates to, potentially increased staff, we would also expect to see a corresponding increase in visits. So in this case, this is where you would file that increase in visits in line 3. Now, I believe the next tab talks a little bit about what is a visit. Yes, it does. Okay, great. So for the visit numbers, we do require that detailed visit reports are filed and are submitted with your cost report. Visits in your facility, I know that you guys have probably seen the SOSA list, the scope of services list, as to what is going to be a qualifying and allowed CCBHC service. So when you determine your visits and how many visits you have had, you will be basing it off of that list. And for us to verify those numbers, we need a detailed visit report that basically shows the calculation of what you have. A visit report will probably look different for every provider. It really depends on what your EHR system looks like, but we kind of provided a very brief example of what that report could look like. It is relatively PHI heavy, as it is claims information, but typically it'll start with, recipient information. We do need provider or patient specific details so that we can identify duplicates and that kind of thing. So you'll have some identifying information, date of service, what is the CPT code or procedure code that was performed, and then payer, as well as the various different amounts. A note on the payer, I think I've mentioned it a few times, but this cost report is supposed to be for all costs, all visits, no matter of payer. So when you are identifying your visits and calculating those, it is not just your Medicaid visits, it is your Medicaid, your uninsured, your private, your Medicare, whoever it is 100% of your visits. Just some more information on the visit documentation. All activities that trigger an enumerated visit must be documented in the user's medical record. And as I mentioned, it must be it must be given to us with your cost report submissions so that we can verify and recalculate those visit amounts. And I know you guys have talked a lot about the scope of services, but we do have those PPS qualifying versus allowed. So, costs associated with CCBHC allowed services, those are included in your allowable cost. However, those visits are not considered enumerated visits. It's only the PPS qualifying visits, as in the visits that you will actually receive the PPS rate for, that should be filed as a enumerated visit. Okay. Next, moving on to the services provided tab. The services provided tab, now this is a informational tab for you guys and for us. However, the state still has requested that it is completed and completed accurately. And it is something that we do look at in our cost report review. But when I say it's informational, really I just mean that it does not impact your PPS rate itself. The services provided tab, this just provides some more information on those visits that you're providing. Here you should be filing the FTE staff equivalent for each of the positions that are filed on the trial balance tab, as well as the number of services that are provided by that person or by that staff level. it should reflect the total amount of CCBHC services provided. If multiple procedure codes can be billed, then multiple services should be counted in this case. And really, again, we're just looking to see how many staff do you have at each position and how many of those, how many services are being provided by each position at every single level. Okay, we're almost through it. Next, we have a comments tab. This is another free form tab for you guys to provide any comments, additional explanations, or anything that you think it's important to kind of call out in your cost report. So specifically, you can see here on the left side behind this box that's kind of covering up here, you're able to identify a specific worksheet, a specific line number, and then you're able to add specific comments. So an example here, let's say you made a reclassification and under that reclassification, we asked for just a very brief explanation of what it is, but you think it would be a little bit more helpful to provide some more detail. In that case, you could come in here and you could say, okay, worksheet, trial balance reclassification, line number 1, and then in the comments, you can just include whatever that additional information is. Again, the comments aren't necessarily required, but anything that you guys think is important to call out, anything that you guys are doing that may be a little odd, anything to just provide some more information is always helpful. So this is here for you. Next, we have the PPS rate tab itself. So I mentioned the whole purpose of this cost report is to calculate your PPS rate. So at the end of the day, once you fill out your cost report, you will be able to see what your kind of initial estimated PPS rate is. Obviously, your cost report will have to go through a cost report review. It'll have to be approved, but you will be able to see what that rate potentially might look at. Almost everything on this tab is formula driven. Again, grayed out cell, you don't have to worry about it. It's pulling from somewhere else. The only item here is the MEI, or the Medicare Economic Index. This is a percentage. I mentioned that the rate itself is just cost divided by visits times an inflationary metric. This is where the inflationary metric comes in on the PPS1 tab. This is something that we will most likely calculate for you guys, and we will send out to you during your cost report while you guys are creating your cost report amounts or cost reports themselves. This isn't something that it's just a calculation that CMS kind of sends out. There's a workbook. So we will provide this to you when it is time so that you guys don't have to do that calculation yourselves. Okay. And then last but not least, we have the certification tab. All of these cost reports do need to be signed by an officer. Typically, that's, a CEO, a CFO, authorized delegate. Really, it's just if it's somebody that can legally sign for the organization, they should be signing this. Essentially, what this is you're just saying, you're not being fraudulent in your cost report submission. Everything that you're filing in here, to your knowledge, is accurate. And that you're not knowingly trying to deceive anything or anything like that. We do require these certifications to be signed as part of the cost report submission. If we do not receive a signed certification, we will not accept the cost report submission itself. And then I'll also note if any changes are ever made to the cost report, it will have to be recertified because the original certification obviously went with the original filing. And also, just as a side note, this is specifically certification for the cost report. This does not have to do with, facility CCBHC certification. That is a whole nother thing. Okay. We have a couple slides for the cost report submission overview, kind of what that's going to look like. And then I will open it up for any questions that you guys have. So the cost report submissions. So The current submission timeline is still, not determined. We will communicate that, or Louisiana will communicate that as soon as they have it. But once that is determined, this is what you guys can expect. You can expect to receive a packet from us, from Myers and Software, that will include three main things. One is a cost report request letter, which we'll go over here in a second. And then the cost report template itself, as well as the cost report instructions. As a note, Louisiana has chosen to make a few minor updates to the cost report template and cost report instructions. So you will receive Louisiana-specific cost report template and cost report instructions. But we have linked the national CCBHC cost report and the national CCBHC cost report instructions in this presentation. If you guys would like to go take a look, they're linked here. They're also very easily Googleable. If you just kind of search CCBHC cost report, it's most likely going to be the first thing that pops up. Just know that there will be a small amount of information in there that is not necessarily applicable to you guys in Louisiana, but the general format of the cost report is the same. For the cost report request letter, the purpose of this letter is just to inform you that it is time to create and submit a cost report. We'll, obviously give you a deadline, as well as the very specific information as to how you will submit. But we also explain what needs to be submitted. So obviously we've run through the cost report itself here, but we will need some additional information from you with the submission. Specifically, those are the detailed trial balance. So that's your trial balance itself. The crosswalk and mapping that we talked about earlier. When you guys do that process, make sure you keep it, because we'll need it with the submission. The daily visits, supporting documentation. If you have a federal indirect rate and that's what you're using as your indirect cost allocation methodology, you should have a letter explaining what the rate is. We will need that. We need the signed certification itself. And then any explanations, calculations, supporting documentation for if you're making adjustments, reclassifications, as well as, most importantly, your anticipated cost. So typically, we'll just get kind of like a spreadsheet here where you'll identify these are all of the anticipated costs that we have. Here's a brief explanation for them for every single one. If you are planning on using a DCO, an explanation and calculation for how those DCO costs were calculated, and then also detailed support for your FTE staff and the services provided. So that's that services provided tab that we ran through. We would like to have the support for that as well. There's some PPS resources in here. There's quite a lot of information about CCBHC PPS rates out there, just kind of in the world right now. So feel free to take a look at these if you have some additional questions. I would just keep in mind, Louisiana, you are doing PPS1, which is a daily rate. There is an option for a monthly rate that some other states do. So as you're going through, focus on the PPS1 information, because the other stuff is not applicable to you. But feel free to go to these links after the case. And that is it. So I know that was quite a lot of information, and I know everybody will probably need some time to digest. While hopefully you guys are thinking of your questions, I'll just give the plug. When it is time to complete the cost reports, we do plan on having TA sessions, kind of office hours, where we'll set a time, and if you have a question, you can pop in, ask your question, and then leave as you would like. So we are here to provide technical assistance, but with all of that, if there's any questions, happy to answer them in the next 10 minutes or so.
Go ahead, Brad.
Hey, thanks. I just couldn't hear something you said right there toward the end of the formal presentation. You made a comment about that the application has to be signed by someone. That's good for the original. Did you say if something changed, you had to re-sign that or reaffirm that or something?
Yes, that's correct. So, you guys are going to create this cost report. It'll come to us. We'll be doing a review. If there's like if we make an audit adjustment to it and like a number changes, or if you guys, during that process realize that you need to change something in the cost report, anytime a number changes in that, it'll just need to be re-signed. That's all that was a reference to.
Okay, thank you.
Yep.
Alice?
Great, thank you. So we're an FQHC and a CCBHC. I just wanted to confirm that our behavioral health visits, which could be classified under our FQHC or our CCBHC, as long as we're just have a methodology for separating out and only counting them towards one, that's sufficient, right? Like we could choose whether they're counted as an FQHC visit or a CCBHC visit.
Yeah, so that's a complicated topic. I'll tell you that now. Generally speaking, yes. I mean, you cannot have it on both sides. It is either going to be a CCBHC visit or an FQHC visit. So you will have to come up with a methodology of splitting the two. I don't know if it might be helpful to have a more specific discussion on the FQHC topic because there's a lot of considerations there as well. Yeah.
Thank you. Yeah, that would be helpful.
Sorry, this is Tara Clark. I'm also with Rob. From a rate setting perspective, I mean, typically you already have, likely your FQHC rate established. And so for the purposes of this, if it's a CCBHC eligible visit, then you would want to put the cost in there to have that factored into your rate. If it's something that you know that you will not be billing on the FQHC side for, then obviously that would not be in the FQHC rate and it should be in here. I think the cost can go, if it's a service that could be in either, you should put the cost in here. However, I think it's really important to know that you should only be billing one to Medicaid. You should not be billing both, even if they're both could be a cover service. It's, you typically would be billing the CCBHC if it's the CCBHC service. And then then you'd bill the FQHC for any non-CCBHC services, I think is typically kind of how that works unless otherwise, told. So I think it's just, if it's a CCBHC service, then that should be included, in this rate. And if the plan is that the CCBHC would be billed, then that's what goes in here. And then anything else that wouldn't be, that's where you do your allocations and just make sure that they're not within this rate if it's a true FQHC service outside of this.
Alice, how I kind of thought about it, and I don't know if I'm thinking about it the right way, but we do have people who are enrolled in CCBHC, and then we have just people who come in to our clinics for services. So I'm wondering if maybe that's not how we make the distinction.
I was thinking of not doing it not by patients, but by provider. Because I think trying to do it by patients could get really complicated for us at least. So I would recommend, my thought was that we would either, for example, an LCSW would be under the CCBHC or a psychiatrist would be under the CCBHC and then not billed with our FQHC rate.
I think that's an interesting way to look at it. Probably a cleaner way to keep it.
That's my concern, that this is going to get really complicated there's only two of us that are FQHC and CCBHCs for now.
Yeah, definitely. It sounds like you're on the right track of thinking of how would it be easiest and best to separate so that there's not duplication there.
Right.
Certainly, if you have staff that are just going to be billing for one or the other, that is obviously a clean way to do it. If you do have staff that would cross over, though, that's where some sort of allocation methodology would be needed, to allocate their service time. But as Rob mentioned, as you're getting into that, that's where we could have, one-on-one or additional TA sessions just to kind of, help you with that process.
Any other questions from anybody else? Okay, well, I'll just add, once you guys get these slides, you'll see, so we do have an appendix here, and all this is just a few slides from the original presentation talking about a few of those documents that are important to know and some things that you'll need to file with your cost report itself. So again, we do still have a few minutes if there's any other questions, but if not, I'll hand it back to you, Christine.
Thanks, Rob. I want to thank everybody for joining today too. You guys have some really great questions, and I'm really glad to hear that you guys are considering what this is going to look like as we move forward, because it is a lot of information. Sounds like we're out of questions at the moment. If anybody does have questions, you guys have Rob and Tara's emails on those slides. You are also welcome to email myself as well. I can get those questions over to Rob and Tara. And again, just thank you for all your time this morning.
Thanks, everybody.
Thank you.
You'll have a great Monday.